Good afternoon, everyone. Thank you, Charmaine, and thank you, Ken. I'm not sure if he's here yet or not, for invitation and all the arrangements. I'm Khosro Farhad. I'm a neurologist working in Wentworth-Douglass Hospital in Dover, New Hampshire. And I work closely with Dr. Anne-Louise Aucklander in Mass General, treating patients with fibromyalgia and a small fiber neuropathy. It's a great pleasure to be here today and talk about the correlation between fibromyalgia and a small fiber polyneuropathy. First, I go over the definition and diagnosis of fibromyalgia, but for the rest of my talk, I will focus mostly on a small fiber polyneuropathy. Fibromyalgia is a chronic widespread pain syndrome with fatigue, cognitive difficulties, and sleep disturbances. There is also a long list of other associated symptoms along with these disabling symptoms. After osteoarthritis, this is the second most common rheumatological disorder, and 2 to 8% of the population are affected. Based on 2011 modified American College of Rheumatology criteria, fibromyalgia is diagnosed based on the number of full body areas and severity of the symptoms. The need for tender points were eliminated from this criteria to make it easier for primary care physicians to diagnose more patients. These symptoms need to be present for at least 3 months, and other causes should have been ruled out. This is a sample questionnaire that patients can fill and see if they fulfill the criteria for diagnosis or not. So the first box here is called Widespread Pain Index. So the body has been divided into 19 different regions, and patients can mark wherever they had pain at least for the past 7 days. And these include jaw, shoulder, upper arm, lower arm, hip, upper leg, lower leg, neck, chest, abdomen, upper back, and lower back. So if you mark one of these, you score 1, and the sum of these scores will be the score of the first box. The second box includes the severity of these 3 symptoms, which includes fatigue, trouble thinking, and waking up unrefreshed. And the score is 0, means that they don't affect the life, or 3, which is they're severe and affect daily activities. The next question asks about other associated symptoms, and they can get scored. The last box asks about duration of these symptoms, which should have been at least 3 months, and no other reason for the symptoms should have been known. If patients score at least 7 here and 5 here, and answer yes to both of these questions, they get diagnosed. If they score between 3 to 6 here, they need to score at least 9 or more in this box, and again, answer yes to both of these questions to get the diagnosis. It's just purely based on the symptoms. And as you notice, fibromyalgia is a label for a collection of symptoms, and it does not meet the criteria for a disease, which usually has abnormal finding in the test and has a more robust definition. It means a lot of patients with fibromyalgia could have different underlying medical conditions that present similarly. The cause or causes of these symptoms are unknown. It is unclear which organs, cells, or molecules are involved. Therefore, it's challenging to develop a test to diagnose the patients. So for a long period of time, they studied the peripheral tissues, and they couldn't find any abnormalities. And then they did some studies in the brain and the spinal fluid, and they found some findings. And the theory of central sensitization was brought up. It means that the brain and the spinal cord of these patients have low threshold for pain, so they're more susceptible to perception of pain without any abnormality in the real area of the pain. This theory was the only viable explanation for widespread pain in these patients up until recently. Recent research shows evidence of a small nerve fiber dysfunction in a group of these patients and changed our understanding about fibromyalgia. So Dr. Aucklander, as the pioneer in this field, published 2 papers in 2012 and one in 2013, and reported abnormal findings in the small nerve fiber of these patients, up to half of these patients with fibromyalgia. So this shifted our understanding, and now we know that it's not all in the brain, so there is some peripheral component to fibromyalgia, at least in some groups of patients. It drew a lot of media attention, as you can see here. The first paper was a study on patients under age 21. There were 41 patients with chronic widespread pain, and they were predominantly female, and a lot of them were disabled. These patients underwent testing for a small fiber polyneuropathy. These testing, which I'm going to explain in future slides, includes skin biopsy and autonomic function testing. And in this group of patients, 59% had abnormal findings that fulfilled the criteria for the diagnosis of definite small fiber polyneuropathy. It means that there was objective findings that they had problem with their small nerve fibers. The next paper that she published was in adult patients, and it showed 41% of the skin biopsies of 27 fibromyalgia patients, and showed evidence of a small fiber polyneuropathy, while only 3% of the skin biopsy of 30 healthy control subjects had abnormal findings in their small nerve fibers. So similar reports have been published by different groups from different parts of the world. So it means that this concept is a valid concept and it's reproducible in different patient population. This is a German paper that they did skin biopsies in patients with fibromyalgia, and they reported that the average of their number of the small nerve fibers in the skin were lower than control subjects. This is another paper from Dr. Caro in California. He does a lot of work on fibromyalgia. He reported 41 patients with fibromyalgia, and 47 control subjects underwent skin biopsy. And the number of the small nerve fibers were overall lower in fibromyalgia group patients. The next report is from Greece. So they had a large patient population, 46, that fulfilled the diagnostic criteria for fibromyalgia. 15 out of 46 had abnormal findings in their small nerve fibers, which is 32%. Another paper from Italy, so they did similar testing on 20 fibromyalgia patients, and 6 of them had evidence of small fiber polyneuropathy. So what is small fiber polyneuropathy? So it simply means the damage to a small nerve fibers. And what are small nerve fibers? Our nervous system is composed of central nervous system, which is brain and the spinal cord, and peripheral nervous system, which connects brain and the spinal cord to the rest of the body. Central nervous system it processes all the information that gets from the peripheral nerves and controls other organs. This is a cartoon of a peripheral nerve. As you can see, a lot of nerve fibers are bundled together in a group of nerves which we call fascicle. If we cut this fascicle and look under microscope, this is what we see. You can see a lot of different nerve fibers are there. Some of them are large with a thick, dark rim around them, like this one. And this is a large myelinated nerve fiber. So that dark rim is myelin, which helps for the nerves to conduct electricity faster. These nerves are responsible for our balance and movement, and they are very important. On the other hand, you see other tiny nerves, like these ones, that they have almost no or minimal myelin around them. So these are the small nerve fibers that we are focusing today on. So what is the function of the small nerve fiber? They have a lot of sensory functions. They transmit sensation of pain, light touch, temperature, and itch. Patients with a small fiber polyneuropathy will experience widespread pain and maybe itching, and they have a numbness. So they explain the sensory changes as these are the terms that patients use: tingling, pins and needles, electric shock-like pain, cold-like pain, burning sensation, feeling of a wrinkle in a sock that cannot be removed, small pebbles or sand in the shoes, and the skin in this patient is sensitive to touch. This is one of the common complaints of the patients, that the bed sheets feel painful at night, especially when it touches their feet. So they have to wear socks or form foot tents to prevent the bed sheet to touch their feet. The other important function of the small nerve fibers is that they perform as the peripheral arm of a very complex and important system called autonomic nervous system. So these patients that have impaired function of this system have dysautonomia. And what is dysautonomia? So this system controls production of tear and saliva. So these patients may experience dry eyes and dry mouth. The other function is focusing with the eye, accommodation, and these patients can have blurry vision and difficulty focusing. Cardiovascular system is extensively controlled by this system, and when we stand up, between 10 to 15% of our blood is pulled to our veins, especially in the legs below the heart. These nerves are supposed to work as a reflex and be able to squeeze the veins and get more blood available for the upper body, so heart can pump it to the brain. So this doesn't happen, and when these patients stand up, the blood pressure drops and they have hypoperfusion of the brain. They don't get enough blood circulation to the brain, and they feel lightheaded, confused, foggy. They may lose consciousness, have syncope. As a reflex, heart may start racing, and they may feel palpitation, chest pain, or shortness of breath, and they may feel fatigued all the time. So this is a very disabling syndrome called POTS, or postural orthostatic tachycardia syndrome, which is a subtype of dysautonomia. Our digestive system is controlled by autonomic nerves, and dysautonomia can cause gastroparesis. So these patients can have early fullness, bloating, nausea. Intestinal function may be impaired, so they have constipation or diarrhea. So these symptoms, I'm sure you're familiar with IBS, or irritable bowel syndrome, is dysautonomia in our digestive tract. Bladder dysfunction is another complaint in these patients. They may not feel the fullness of the bladder. They may have incontinence, or they may have urinary frequency. And sometimes they cannot initiate the urine stream, and they have to strain more. Sexual dysfunction with erectile dysfunction in men and painful intercourse in women. This system also controls sweating, and these patients may have reduced or increased sweating based on which type of nerves involved. How do we diagnose a small fiber polyneuropathy? There are two patterns of neuropathy overall. So one pattern is length dependent. It means that the problem with the nerves starts with the longer nerves. So those are the nerves that usually go to the feet. And when we examine these patients, they have reduced sensation to pinprick and temperature in the office, especially in the feet or hands, and it returns to normal in the upper parts of the arm and leg. Some of these patients may present with non-length dependent sensory loss. So the sensory loss could be patchy all over, involving long and short nerves altogether. So physical examination may help in the reduced sensation. They might have changes in the skin. When we look at the skin, it might look a little bit shinier. They may lose hair in the lower part of the leg. We can check their heart rate and blood pressure in the office, lying down and standing up, what we call orthostatic vital signs, to see if there is abnormality in the cardiovascular function because of dysautonomia in these patients. And sometimes physical examination is not helpful at all. Some patients may have normal neurological examination, and we see a lot of these patients on a daily basis. When we suspect a patient has neuropathy or numbness, the first test we do is EMG, or electromyography and nerve conduction studies. It involves electrical shocks and small needles to check the muscle activity and also nerve function. This test in these patients is normal. because these techniques check only the large nerve fibers, not the small ones. Sometimes we need to biopsy the nerve. So the typical nerve that is biopsied is sural nerve, is a large nerve at the ankle. So this is a difficult procedure, difficult in terms of it is complex because it needs an operating room. It's a surgical procedure. It may leave an area of constant numbness in this part of the leg and the foot. And this area of the biopsy might be painful for a long period of time. They look at the nerve under the microscope and they can tell if the patient has lost the nerves or not. So this is not an easy test, and we rarely order that because there are some other simple ways of measuring small nerves, and that's a skin biopsy. This is a very simple and safe office procedure that can be done by any physician. This is one of my patients, so this is the ankle area. We mark 10 centimeters above the ankle, and under a sterile condition and local anesthesia. With this skin punch device, we take 3 millimeter skin, which is this tiny bit here, and put it in the fixative, and I send it to Mass General to be read at Dr. Oaklander's lab. They count the small nerve fibers in the skin of these people. This biopsy also can be done from the upper thigh to compare the numbers from the upper thigh and lower leg. This is how it looks under microscope. So these are both our 18-year-old male patients. The first one is not a patient, is a control, but the second one is a patient. You can see these are the small nerve fibers that can, they count, histopathologists count these, and they report the number of these nerves, which we call axons, per square millimeter. This is a normal number for this age and sex. So there are normative data based on age and sex in each lab. And this person has lost a lot of these nerves, as you can see, and has only 155 per square millimeter. So this patient has a small fiber neuropathy, and this is a normal subject. The other way of measuring the functions of small nerves is autonomic function testing. So as I told you, because these nerves control a lot of organs, we can check those organs and the function of them and see if these nerves are working properly or not. So the most common test is tilt table. So patients will be hooked to monitor, so to have the constant monitoring of their blood pressure and heart rate. And these numbers will be recorded while patients are flat, and then they will be tilted between 60 to 80 degrees, and we record the changes. So we record the changes of the heart rate and blood pressure when they blow into a tube under pressure, which is called Valsalva maneuver. And again, there are different phases of that, and we record how blood pressure and heart rate respond to this maneuver. Sweating can be tested, so there are different techniques. So acetylcholine is a substance that they infuse in the skin, and with the cameras they can count the number of small sweat droplets, and we can tell if a patient has normal sweating or not. There are other testing, but I did not include it here, that can measure different parts of autonomic nervous system. What are the causes of a small fiber polyneuropathy? The most common cause is either diabetes or borderline diabetes. If patients have thyroid problem and it has remained untreated for a long period of time, that can affect the nerves, that can present with neuropathy. Some autoimmune diseases like Sjogren's, sarcoidosis, rheumatoid arthritis, and lupus can cause small fiber neuropathy. Vitamin B12 and B6 deficiency can cause a small fiber neuropathy. And something tricky about vitamin B6 is that if patients get toxic on vitamin B6, by taking a lot of vitamin B6 supplements, they also can present with neuropathy. Excessive alcohol use is a known cause. Celiac disease or gluten sensitivity is another cause. Some infections like HIV, Lyme, hepatitis C, and rarely hepatitis B because it mostly affects the large nerve fibers. Some medications are toxic to the nerves. Typically, some chemotherapeutic agents, some antibiotics that you use for urinary tract infections, some anti-HIV medications. There is a condition called paraproteinemia. So this means that there are proteins that are called monoclonal proteins. These are abnormal and produced in the bone marrow, and they can be toxic to the nerves. There are a lot of subtypes and syndromes associated with that. Amyloidosis is a condition that has different forms. One form is hereditary amyloidosis, and that's because the body cannot process a protein, and that protein can get deposited in nerves, kidney, or heart and cause a lot of problems. Cancer sometimes can present with neuropathy. So as part of a paraneoplastic syndrome, it means cancer is somewhere else, is producing some toxic substances that they can damage the nerves and present with neuropathy. This is something that I usually consider in almost all my patients when I don't find a clear cause for the neuropathy. Some types of these neuropathies are hereditary and can be because of a genetic problem. Despite all this workup we do to look for all these diseases, still some patients remain idiopathic. It means that we don't know why they have neuropathy. But in a lot of patients, we can find a known reason. This is a sample of the lab requisition form in Mass General for patients with suspected or confirmed small fiber polyneuropathy. So it depends on the physician that decides which one of these tests are necessary for each patient based on age, gender, history, and other factors. But this is what Dr. Oaklander developed and uses in Mass General. Almost everybody uses the same form. How we can treat these patients after diagnosis, the best treatment is to be able to find the cause and treat the cause. The nerves have the capacity to regenerate and grow back if you be able to find what is damaging them and prevent that from happening. A lot of times we cannot find or we cannot treat the underlying cause, and we use other medications to control pain. Neuropathic pain medications typically include antidepressants or anti-epileptic medications. Typically we use nortriptyline, duloxetine, and sometimes milnacipran is helpful. Gabapentin, pregabalin, oxcarbazepine, and sometimes lamotrigine can help. If pain is severe, we may need opiates, and sometimes some topical agents can help to reduce the sensitivity in the skin. In some subtypes of patients that have severe symptoms, and we cannot treat those symptoms with these measures, we may use immunomodulatory agents such as IVIG or intravenous immunoglobulins, steroids, and some other immunosuppressive agents. There is a thought behind that a lot of these patients have an underlying unknown autoimmune condition that is damaging the nerves, and if we modulate the immune system, these patients may feel better. And these treatments are not still FDA approved, but we have a lot of patients that we have to use these agents, and we have seen a lot of success in that. So what are the recommendations for patients with dysautonomia that affects their cardiovascular system? So to stand up slowly to prevent the drop in their blood pressure, especially after eating, urinating, or bowel movement. Increasing salt and fluid intake is important to increase the blood volume. So it's recommended to drink at least up to 2 liters of water daily and maybe up to 10 grams of salt. To elevate head of the bed helps to keep the veins under some constant pressure, and that prevents sudden drop in the blood pressure when they stand up, so that might be helpful. Up to a couple of inches, the head of the bed can be raised. Compression stocking and abdominal binders help to squeeze the veins and get more blood available for the rest of the body. Maximizing tissue oxygenation, such as no smoking or aerobic exercises, can help. Some situations can worsen the symptoms, such as in flying and high altitude because of low oxygen. And if patients have anemia and low albumin that needs to be treated. Sometimes we need to refer these patients to some specialties that they treat that specific organ. For instance, if they have a lot of cardiovascular symptoms, you need to find a cardiologist with a lot of experience treating dysautonomia patients. We usually send these patients to Dr. Grayson in Mass General. And for GI symptoms, which could be quite disabling, also we mostly need to use one of the specialists in Mass General, Dr. Ko, who is subspecialized in nerves of the stomach and intestines, and he helps these dysautonomia patients. In conclusion, so evaluating patients with fibromyalgia and chronic widespread pain syndrome for presence of a small fiber neuropathy open avenues for treatments. Skin biopsy is a very simple procedure that can be done in any office for any healthcare professional. But it's important that the skin samples need to be sent to a place that has experience in reading the number of the small nerve fibers in the skin. Mass General is the only hospital with normative data on young adults, teenagers, and children. I'm talking about the number of the small nerve fibers on the skin. And the biopsy, skin biopsy, can be ordered by any doctor. The forms are available at neuropathycommons.org website. This is a useful website. You can see local providers who do a skin biopsy, and also you can find the requisition forms for a skin biopsy. And blood tests are essential in patients with a small fiber neuropathy, as in some of them we can find a definitive diagnosis and put them on the right treatment. And thank you for your attention.